Good morning and welcome to PI Today podcast. I hope all of you had a great summer. We've been on break, a summer break. Obviously, it's tough to get hosts and physicians here when it's summertime, but the break is done. I hope you guys were safe, enjoyed it, and as usual, back to business. I have no idea where this year is going. So I'm Dr. Nick, your host, and today we have a special physician here for you guys, Dr. Stephen Narvy. He is an orthopedic extremity surgeon. Doctor, thank you for coming on the show.
Thank you very much for having me.
Of course. So, Doc, I kind of want to put out there the difference between orthopedic spine surgeon and an orthopedic sports and extremities, and what does the extremity orthos most of them specialize in different things. What's your specialty, and what is it? What is that you do?
Sure. So I do primarily sports medicine and arthroscopy. So I specialize in surgical and non-surgical treatment for various conditions involving the shoulder, elbow, hip, and knee primarily. My practice focuses on surgical and non-surgical care. I do arthroscopy of all of those joints. I do shoulder replacements. I do ACL reconstructions and meniscus surgery, rotator cuff surgery. A lot of common things that we see.
Okay. And the difference between an orthospine and orthoextremity, I know it's simple to say just in the word, is that you do the extremities and an orthopedic surgeon that does spine pretty much strictly does the spine. Is that correct?
Yeah, most spine guys just do spine, and most of us who don't do spine stay very well away from the spine.
Okay, fantastic. And tell us about some of your schooling
Sure.
to the audience.
So I am a Trojan all the way through. I went to undergrad, med school, residency, and fellowship all at USC.
Wow.
So yeah, I was there.
You don't have a building named after you?
I
by now?
wish. I didn't give enough money, I guess.
Right.
I was there during the heyday of when USC had an amazing football team. So now we're just recovering.
I got you. I got you. And how long was your residency, fellowship, all that?
Sure. So orthopedic residency is 5 years. So I was at the county USC hospital and the university hospital there for 5 years, learning all kinds of aspects of orthopedics. And then I did a 1-year fellowship in sports medicine and shoulder elbow reconstruction, also at USC.
That's fantastic. So, what type of injuries that result from a personal injury, whether it's car, slip and fall, they get crushed, something falls on them. What do you primarily see in your practice when it comes to personal injury?
So probably from a shoulder standpoint, the most common thing that we end up seeing is rotator cuff tears when people are in car accidents or fall and they either dislocate their shoulder or fall directly on it. They can injure their rotator cuff, or just from having their arms braced against the steering wheel when an impact happens, they'll injure that. I see a lot of meniscus tears from people who slip and fall on wet surfaces or uneven pavements and damage their meniscus or sometimes their ACL. Those are probably the most common things I see.
Got it. And of course, non-surgical. If there are fractures, do you do the casting as well or the bracing?
Yeah, thankfully most of the shoulder fractures don't need a lot of casting, but yeah, that's something that we do. And then obviously patients need a lot of rehab afterwards from physical therapy, chiropractors, whoever they're seeing.
Got it. Obviously, you would know better. Some of the surgeons, if it's not clear in an imaging in an MRI, do you do a scope to kind of investigate further? Is that the procedure? Is that the
Yeah, so I would say the majority of the time we get a pretty good answer based on the imaging. There are in-office needle arthroscopy procedures that you can do if there are any questions, but I'd say the majority of the time with a good physical exam, a good history, and MRI scans, you can usually figure out what's going on.
Now, does the MRI scan truly matter? Let's say between a 1.5 or a 3.0 Tesla. Can you still see the same findings that you're looking for, or you prefer a clearer image like a 3-point Tesla?
I mean, all things being equal, obviously we'd rather have better than less ideal imaging. But I'd say for the majority of things, 1.5 is fine. Really, the 3 Tesla really comes into play if you're looking for little cartilage injuries. Sometimes the 1.5 Teslas don't catch it. But for the vast majority of problems, you can see a rotator cuff tear, a meniscus tear, what have you, on a regular MRI scan.
And you would need your patients, obviously, to bring in their own MRIs. You just don't go by the radiology report. You would have to take a look at it to see where you
Correct.
operate.
Yeah, whenever possible. I like to see it myself because frequently the radiologist and I think differently about things.
That's actually true, and that's a very important point where the radiologists, you know, I mean, they do a great job, but a lot of them, unless they are a true MSK musculoskeletal radiologist, and they just are looking for these things, and they're reading for sports orthopedic or injury or things like that. Most radiologists, in my experience, is that they're looking for life-threatening things. So if it's a little tear or a big tear or whatever it is, if it's not life threatening and it's not a tumor or a bleed or cancer, that's what they're looking at. So it's really important that the actual surgeon, which I think 99% of the time, actually grab the images themselves, take a look at the surgeons. What we kind of don't realize in the personal injury field is that the true read, whether it's spine or extremities, the true read is done by the surgeon. The radiologist gives an opinion, kind of a guideline where to look at, but the true read with radiology is the surgeon. And you spent in your obviously in residency and schooling plenty of time in radiology looking at these things. Have you not, Doc?
Yeah, we always had imaging conferences where we go over the MRI scans of the patients we were about to operate on. And the other thing to point out, frequently, especially in the shoulder, there's a lot of things that don't show up on the MRI that when you're actually looking directly at them during surgery, you see tears in the labrum, scuffed up cartilage. There's a lot of things that even the best MRIs don't catch. So they are not 100% perfect. So it's very important for us to see whatever we can see beforehand. But sometimes the gold standard is looking right at it.
Yep, that's fantastic. And Doc, where are your practices? Where can the audience refer you client or their clients and your patients?
Primarily Encino and Century City.
Encino and Century City. And where do you operate, Doc?
So I operate at various hospitals as well as Surgery Center in Century City.
Surgery Center. Wonderful, wonderful. And do you only do adults, or do you do any peds?
I do some peds, probably mid-teenager and beyond. I would do.
Give us an age.
Probably 13, 14 and above.
13, 14. Well, that's really important because unless if they're under, they have to be under 18. If they're under 18, most non-peds solely orthos won't touch them.
Yeah.
Which is really really important to know because finding I mean most of our demographics are around that age, 13 and on.
Yeah.
And it's really important to know we can find some care through Doc here. And what does your day in the clinic look mostly? Is it mostly soft tissue, fractures, tears?
Depends on the day. Probably mostly soft tissue things. As a sports medicine surgeon, a lot of what we see is shoulder conditions as people, whether they're had injuries from personal injury type cases or just from life. Shoulder injuries are very common and become more common as we get older. So I see a lot of rotator cuff problems, a lot of meniscus problems, and then in the traumatic population, some fractures. I have patients that get referred to me for various shoulder fractures and things like that. So it depends on the day. Every day is exciting.
Wonderful. Well, we're very happy that you joined us over here, and we look forward to seeing you again. One question: how do you feel about PRPs and stem cells for injections?
Sure. So I think it depends really on the condition that you're treating. I think those treatments are still actively really being studied, but the science is really coming along. I think there's a lot of conditions that are very easily treated successfully with these new biological agents that, maybe 10 years ago, that was not an option to us, and we didn't really have any studies for it. So I really think that's a good tool. It doesn't solve every problem. Certainly if you tear your ACL, stem cells aren't going to grow it back. But for a lot of degenerative conditions, frequently what we see is, especially in the knee, we see patients who have some arthritis that was obviously there before they had their fall or their car accident or what have you. But now they're having problems after their injury. So I think those treatments are very helpful to kind of get people back to their baseline level of discomfort. Patients who had some pain were getting some treatment, they trip and fall, and then it gets much worse. I think there's a good role for those treatments in that population.
Well, there you have it. Doc, thank you for joining us, and we'll see you next time on PI Today's podcast. Have a great fall, and if I don't see you, happy Halloween.